Hello, good morning, everybody. I'm Dr. Karen Domino from the University of Washington in Seattle, and I'm excited to do my presentation today regarding the Anesthesia Closed Claims Project. Let me just share my screen and get ready to do this presentation. And we'll begin our slideshow. So this is on the Anesthesia Closed Claims Project, and you see down below, you have my email address. I'm happy to respond to any questions via email. Now, as far as my lecture, I have no disclosures relevant to this lecture. The Closed Claims Project is funded by the Anesthesia Quality Institute, which is a part of the American Society of Anesthesiologists, and it is a patient safety organization. I personally have a research grant from Edwards Life Sciences for a clinical trial of a device that's not related to this subject. It's the Hypotension Prediction Index, and I won't be describing anything about that device in this lecture. What I plan to do today is to talk about injuries and their clauses in the Anesthesia Closed Claims database. In particular, I'm going to focus on management problems dealing with difficult tracheal intubation and aspiration of gastric contents. I will also be talking about situational awareness errors and problems with communication failures as well. These are areas that we have published papers in recently. There is a website, if you see down below, about the Anesthesia Closed Claims Project. It doesn't include a lot of information about it, but it is one, if you're a member of the American Society of Anesthesiology, that you're able to obtain some data from the Closed Claims Project. Now, I've always found the study of malpractice claims to be fascinating, but there are issues related with these claims. They are retrospective. We don't have any denominator in the United States. We contract with participating insurance companies, but we don't know how many, say, general anesthetics the anesthesiologists do versus regional anesthetics. So they're really a series of case reports, in essence, and they form just like the tip of an iceberg. It forms a small subset of all injuries, because these injuries that result in a malpractice claim are generally severe permanent injuries. They generally have more substandard care. But I do think they highlight areas of risk in our specialty and give us some assessment of what went wrong, so we can change our practice and learn from that to do what may work better. As far as the areas in anesthesia practice, the majority of these are surgical or procedural anesthesia, including non-operating room anesthesia. We have a smaller number relating to management of acute pain, usually generally on the ward, obstetrical anesthesia, and a little bit more relating to chronic pain medicine. Overall, there are now over 11,000 claims in the database. We've had a few years of hiatus with COVID. We haven't gotten new claims recently, but we are starting to go back and visit to the insurance companies now that they're beginning to open up to visitors. The claims we see are generally bad injuries. They include about a third of death, nerve damage that's permanent in 21%, permanent brain damage, usually severe airway injuries, including hoarseness, but also things such as esophageal perforation and resulting in either death or poor outcomes or long ICU stay. We get some relating to burns and emotional distress. About a quarter are other type of problems. These are the ones that we often think about, like aspiration of gastric contents, myocardial infarction, newborn injury, stroke, awareness, and eye injury. These are less common in the database. What primary damaging events are what we classify as the cause of the patient injury, and they include our things that we do, right? We give blocks, we deal with respiration, we have equipment such as central venous catheters, or intravenous catheters that may cause some injury or cautery-induced fires with oxygen. There may be some issues with patient or procedure and type of surgery, cardiovascular problems, and a variety of other type of causes for these claims. Now, over time, the project was started in 1985, and it looked back retrospectively since it takes time for the malpractice claims to settle. And we found in the old days, a lot of the claims against anesthesiologists were related to hypoxemia and inadequate ventilation and oxygenation, either due to things such as unrecognized esophageal intubation, or problems during monitored care and sedation, where people, it wasn't picked up that the patients weren't adequately ventilating. And about 60% of the claims were related to death and permanent brain damage. Over time, what's happened is the number of claims seem to have kind of settled out. They have decreased in the number of claims that are for severe injuries, the death and permanent brain damage. We did note that the initial decline was associated with the change in practice in the United States with the standard of pulse oximetry and the standard of use of end-tidal capnography. However, since this time, things have kind of, as I said, settled out. Around 40% of our claims are these severe claims. And there are a number of reasons why. One of the big things I want to emphasize is that we see a lot of these related to human factors, skill problems. These include our issues with decision making, leadership and teamwork, because we do work in teams, team communication, and situational awareness problems, and occasionally one of overworkload and workload management. One of the things to really emphasize, and I think this article is a fascinating article, deals with the cognitive processes involved in decision making. And we all use shortcuts. We all tend to anchor our decisions according to where we think things are really happening, and our previous experiences. There's a problem with confirmation bias. We think that endotracheal tube has gone through the vocal cords, and and even though things aren't going well, we forget that maybe it might be an unrecognized esophageal intubation. We have problems with fixation and trying the same thing over and over again, occasionally one of overconfidence, and and a bias that it's easier to not act than it is to act. And so these kind of cognitive processes do influence our decision making in these cases. Now, I wanted to focus a bit on the two areas that I mentioned of injuries. One was with a management of difficult tracheal intubation, published in Anesthesiology in 2019. Now, what we did is we looked at difficult intubation events in a more recent time when we had video laryngoscopes available in the United States, and we compared this to a previous article we had written back in the earlier days. And then we found now patients were sicker. Most of these were almost ASA 3 to 4, occasionally an ASA 5 patient. Most were during emergency surgeries, and there were also more occurring in the non-periop locations, such as in the cardiac cath lab or in the, for a rescue in the intensive care unit or in the emergency room. In terms of the locations of these, then we found most of these occurred in the operating room. But again, as I mentioned, there are these other locations that were more common these days than it was in the early days of the closed claims. When we look at when they occur, the difficult airway occurs, it's usually during induction in about 2/3. But keep in mind, this can happen anytime. For instance, it could happen if you've chosen a regional block or monitor anesthesia care to require induction of general anesthesia in the middle procedure. And in someone with a difficult airway, they may this be a problem. Also can occur on extubation in the operating room. Big thing, especially most of these had the induction managed very well for their difficult intubation, but the failure occurred for premature extubation, or it can occur in recovery or ICU. And what we noticed is that the majority of these had preoperative predictors of having a difficult airway. So one would think that the practitioners would be set up in order to handle it. Most of these had judgment errors involved. 80% had a can't intubate and can't oxygenate scenario, and that's why they ended up in the closed claims database. And about 25% had system issues, such as not being able to find the difficult airway cart, as an example, when especially on off hours. Now, the type of judgment errors we saw included the inadequate preoperative airway evaluation. It does happen. We're supposed to have a good airway evaluation, but sometimes people don't do it. I can tell you from personal experience that happened to my father. He was having emergency surgery, and his anesthesiologist, who had provided a regional block before, failed to do an airway exam. And what happened is he didn't realize my father couldn't open his mouth. Fortunately, my father did fine. He managed to ultimately get him intubated, but the anesthesiologist decided to retire after that event. There's failure to plan for a difficult intubation. So, getting your cart and your tools there to begin with, especially in off hours, is important. There was no backup plan for a difficult reintubation. I mean, gee, if someone's a difficult intubation to begin with, or they're having neck surgery or things, that they certainly should have a plan for a possible difficult reintubation. And then we saw management errors, such as trying the same technique without any change other than different providers, failure to use the supraglottic airway as a bridge, and delay in calling for surgical airway. Now, there were ones in these cases that they did try an awake intubation to begin with. However, they failed in these cases. There were 11 cases of this, and the problems were twofold. One was inadequate topical anesthesia, and the other one was using propofol sedation as your sedation of choice for this intubation, and patients lost their airway. We also saw a problem of failed supraglottic rescue in these, and these occurred because there were so many attempts at endotracheal intubation beforehand that by the time they put in a supraglottic airway, there was so much swelling, it didn't work. What I would suggest we did see is that we need to prepare for a surgical airway if we've moved on to a supraglottic bridge. We found a number of complications related to jet ventilation. Unfortunately, in some of the cases, the surgeon disagreed about whether they needed to have an emergency surgical airway. And in other cases, such as GYN and orthopedics and urology, the surgeon lacked any expertise in order to do an emergency airway. And so we suggest that anesthesiologists need to develop the skills in order to do the rare emergency surgical airway that might present, especially if you're in a center where you don't have a 24/7 ear, nose, and throat coverage. Okay, the next thing relates to aspiration of gastric contents. Now, this is a man who's a larger man, who's having an ERCP because he has gallstones. He has one in the common bile duct, and he is nauseated. The anesthesiologist was doing this in a suite, not in a one where it didn't have an anesthesia machine or any end-tidal capnography, even though it is a time that it was recommended that you use end-tidal capnography for these cases. The patient was sedated and the propofol was started. And unfortunately, with the patient being prone, he regurgitated and then became apneic. A large man is difficult to roll, and of course the patient's bed is outside of the room. It was difficult to do ambu ventilation in this size man, and the patient had severe bradycardia, moving on to cardiac arrest. We published our series of these cases back in 2021 in anesthesiology. And we found that the risk factors were ones of largely some sort of GI obstruction, or like in this patient, some sort of acute intra-abdominal process where there was the presence of an ileus. While there are other things that I have there that might be things, the major trauma with recent oral intake was also an issue in some of them. But GE reflux, even though many people had it, that we didn't have any cases where that was caused an aspiration in those cases. About half of these occurred on induction of anesthesia, but they occurred all throughout other times, including during emergence in the phase 1 recovery and postoperatively as well, or during the maintenance of anesthesia, if it's a monitor anesthesia care sedation case or regional anesthesia. We had our experts code what sort of clinical care problems they were. One was that people felt they should have had an NG tube placed in someone with a bowel obstruction before someone goes to sleep. There are problems of management of the aspiration event. There was use of a mask or a laryngeal mask airway in someone who was at high risk for an aspiration, such as a full stomach, a few hours before a major trauma in that, and a number of other problems that we coded. Now, I'd like to move on to talk a little bit about situational awareness errors, and we published this article back in 2017 in Anesthesiology. Now, when we think about situational awareness, we usually think about transportation industry, and this is one I have that happened back in 2017. It was from a ship that was based in Washington State, was off in Japan. And unfortunately, the skipper and the top sailors from the leadership team lost situational awareness, figuring out exactly where they were, and that it led to a fatal collision that left 7 sailors dead. We tried, what we did is we translated this into medicine. And we came up with a variety of issues. There are ones of inadequate perception. In other words, one could ask is what is the information? There's inadequate comprehension. And then one can ask is what does this mean? Examples of those are hypotension and tachycardia. What does that truly mean in terms of the differential diagnosis? And then inadequate projection and what's likely to occur. An example of this might be someone who had a difficult intubation to begin with, but then you fail to plan for having any potential issue on extubation and extubating the patient too early. So we found that these were solo anesthesiologist claims. We got rid of ones where there was a team present, meaning a nurse anesthetist and an anesthesiologist or an anesthesiologist and a resident. And we looked at ones in claims that had death and severe brain damage in them. About 3/4 of these claims had situational awareness errors. They include ones relating to respiratory events, inadequate oxygenation, ventilation, difficult intubation, and aspiration of gastric contents. The cardiovascular events were largely ones of not appreciating hemorrhage that was occurring. And there are other type of events relating to things that, of course, we can have our problems like our equipment, our medications, and our regional blocks. So we find that that they are relatively common then in the claims and the really severe claims. And that one way that we can learn about it is by having further teamwork, and I think working in simulation laboratories can be helpful. We find that they can be improved by reduced by communication, mutual support, such as lists, checklists, calling for help, and leadership in order to ask when you have your help to be able to share your mental models to figure out what's really going on with the patient. We also looked at communication failures contributing to patient injury. And this was published in 2021 in the British Journal of Anesthesia. And we found these were ones where we looked at, and we found that in about 43% of the malpractice claims, there were failures in perioperative communication. And this occurred between anesthesia and surgery. It occurs with nurses preoperatively or consultants preoperatively or postoperatively with consultants, surgeons, nurses, and a variety of people. So here's an example one, a really very sad case. This man was having an elective procedure, and he had hypertension, coronary artery disease, and atrial fibrillation, and was on warfarin for treatment of atrial fibrillation. That was discontinued by his primary care 7 days pre-op. The anesthesiologist went to see the patient and was concerned that the patient was large, he had poor functional capacity, and wanted to order a transesophageal, a transthoracic echo, and canceled the procedure. Unfortunately, in the process, no one told the patient that he should resume the warfarin until the procedure would be rescheduled. And that includes the anesthesiologist, the surgeon, the nurses. No one mentioned it to him. No one called the primary care to discuss it as well. So there was obviously very poor communication involved here. The patient actually had a fairly good left ejection fraction, no pulmonary hypertension, and came back for the elective surgery. But at this time, it was 19 days later, or 12 days later, he had no anticoagulant for 19 days. Unfortunately, he suffered an intraoperative stroke and he died. Now, we found that there are a variety of causes of communication failures. This is one we call a content problem. And that was one where something was not told, right? The patient was not told to resume his warfarin when the procedure was canceled. There are other types of problems we see as well. Maybe it's too late to tell the patient. There's sometimes things that there was a long delay in the communication, so that the effective communication didn't occur. Sometimes one of the participants in the communication was not present. And then there were ones we call purpose, which were disagreements between individuals on what should be done with patients. And these occurred during about half during the procedure, but quite a few during preoperatively and a bunch postoperatively as well in that. So we in anesthesia communicate with lots and lots of folks within our care teams. There are a variety of methods to improve communication. These include the checklists. They include formalized handoffs or TANLIS checklists. There are massive transfusion protocols that make getting blood easier in the event of a major hemorrhage. That sort of alleviates some of the communication issues with the blood bank. And then a lot of us have undergone team training of simulated emergencies. There's something in the United States called team steps that we've had to go through the agency that we've done as well with our surgical and obstetrics teams, or people also have had to undergo crew resource management training as well, all of which helps formalize your communication to have it readily understandable and not anyway, readily understandable. So in summary then, I want to mention that there are a variety of causes of injuries in anesthesia. They include our big areas: respiratory, cardiovascular, regional block, and our equipment that we use. One big issue with the difficult intubation is failure to move along the difficult intubation algorithm rather than just being there, not moving ahead. The aspiration of gastric contents is largely in extremely high-risk patients. These are patients that we really need to have a lot of suspicion and care for to manage them successfully to avoid an aspiration event. And that human factors skills are important in patient safety. They include decision-making, situational awareness, and our communication. So that's it for my lecture. Thank you so much for listening to me. I'm hoping to be there to answer questions, and that's all I have to say. Thank you.